Welcome to the module on laboratory considerations for COVID-19. I am Dr. Céline Barnadas from the Public Health Laboratories training team at WHO headquarters. This module is part of the WHO COVID-19 Clinical Management course series. At the end of this module, you should be able to describe when to consider testing for SARS-CoV-2, to describe different diagnostic tests for SARS-CoV-2, and to describe laboratory abnormalities commonly seen in patients with COVID-19. So there are many reasons to test for SARS-CoV-2, such as individual patient management and public health reasons. A health provider may order a SARS-CoV-2 test in order to confirm an active infection in a patient who is clinically suspected to have COVID-19. That is, in someone who meets a standard case definition of a suspected COVID-19 case. You can see the link on this slide for the WHO global case definition. Another reason a clinician may order a SARS-CoV-2 test is to determine current or past exposure to the virus for appropriate cohorting of patients in a health facility. It is important to keep suspected and confirmed patients at an appropriate distance from patients who are not suspected to have SARS-CoV-2 infection. Some public health reasons to test for SARS-CoV-2 include screening of contacts of persons with confirmed COVID-19 and other screening persons. Different testing objectives require different testing methods. Please see the WHO guidance linked on this slide for more details. When a patient with symptoms listed in the standardized case definition presents to a health provider, promptly consider testing for SARS-CoV-2. Please see the link on this slide for the WHO global case definition. Symptoms of COVID-19 overlap with many other infectious and non-infectious etiologies that the patient may have. Build a broad differential diagnosis based on setting and patient factors. That is, take a syndromic approach to diagnosing COVID-19. A positive test for another pathogen does not rule out a SARS-CoV-2 infection, and a positive test for SARS-CoV-2 does not rule out co-infection with another pathogen or another etiology for the patient's symptoms. Co-infections with other respiratory pathogens, such as viral and bacterial, fungi, infections have been found in COVID-19 patients. As mentioned before, a positive test for another pathogen does not rule out a SARS-CoV-2 infection and vice versa. Testing for additional pathogens should be performed according to local guidance. For example, in malaria endemic areas, patients with fever should be tested for malaria or other co-infections and treated as appropriate. In endemic settings, arbovirus infections such as dengue, chikungunya, Zika, yellow fever should also be considered in the differential diagnosis of undifferentiated febrile illness, particularly when thrombocytopenia is present. Similarly, influenza or other respiratory viruses should also be considered in the differential if the season is appropriate. For more on co-infections, view the module on co-infections and use of antimicrobials in COVID-19, part of this course series. There are three major types of SARS-CoV-2 tests available: molecular tests, antigen tests, and antibody tests. Molecular and antigen tests detect current SARS-CoV-2 infection. Antibody tests, or called serology tests, assess for past infections. Molecular tests detect viral genetic material by amplifying small amounts of viral genome, or RNA, until it reaches detectable levels. This test is usually done in a laboratory. Antigen tests detect viral proteins by capturing antigens on a test strip that changes in color if present. These tests are generally done at the point of care. And finally, antibody tests look for antibodies that patients develop in response to infection by capturing antibodies on a test strip or in a tube that change colors if present. These tests can be done in a laboratory or at the point of care. However, based on current evidence, WHO recommends the use of this new point-of-care immunodiagnostics test only in research settings. They should not be used in another setting, including for clinical decision-making, until evidence supporting use for specific indications is available. The different tests described in the previous slide detect different parts of the SARS-CoV-2 virus. Here you see a simplified schematic representation of SARS-CoV-2 RNA and proteins and human antibodies targeting SARS-CoV-2. As pictured, molecular tests detect viral RNA, the blue string-like part visualized on this slide. Antigen tests detect viral proteins, visualized as the spokes on the virus on this slide. Finally, antibody tests detect virus-specific human antibodies, as visualized by the blue Y-like figure on this slide. There are additional lab tests being used in the COVID-19 public health response. This includes sequencing and culture. Sequencing first. Sequencing allows us to detect SARS-CoV-2 variants by identifying mutations or changes in the composition of the viral genome. It is mainly used for public health surveillance and research. Then we also have culture. Culture allows us to assess the effect of drugs or antibodies on virus growth. Both these tests must be done in specialized laboratories. The probability of detecting SARS-CoV-2 with a different type of test described depends on the time of the course of infection in which a specimen was taken. This graph shows that antigen tests are best suited to detect infection at the time of or just after symptom onset. Molecular tests are best suited to detect infection at or about 2 weeks after symptom onset. Antibody tests, however, detect infection several weeks after symptom onset. This is the reason why they are not the test of choice to detect acute infections. Molecular and antigen tests can detect virus before symptom onset. So, how should a clinician choose which test to order? In general, molecular tests or nucleic acid amplification tests such as RT-PCR is a test of choice for detecting SARS-CoV-2 in a patient who meet clinical criteria for COVID-19. If this test results negative, but there is continued clinical suspicion for COVID-19, resample and repeat the test. If this test results negative again and clinical suspicion remains, consider use of serology test. Once a patient in whom COVID-19 is suspected has tested positive for SARS-CoV-2, he or she may be deemed a confirmed case. RT-PCR, reverse transcription polymerase chain reaction, is a type of molecular assay or nucleic acid amplification test, also called NAT, which detects viral RNA. When performed under ideal conditions, RT-PCR has a high sensitivity and high specificity. To clarify these terms, sensitivity refers to the percentage of SARS-CoV-2 infected patients who are correctly identified as having SARS-CoV-2 infection. Thus, tests with high sensitivity mean there are generally few false negative results. Specificity refers to the percentage of non-infected people who are correctly identified as not having SARS-CoV-2 infection. Otherwise said, high specificity means there are generally few false positive results. As described previously, SARS-CoV-2 molecular assays can be positive regardless of presence of symptoms. Molecular tests can be run in a lab-based setting or at the point of care. In a laboratory, RT-PCR tests are conducted by highly trained lab personnel. RNA is extracted and purified from the patient's specimen. The RT-PCR instrument amplifies and detects RNA. The output will be determination of whether SARS-CoV-2 RNA is present, as well as a CT value. CT value refers to the PCR cycle at which the amplification of SARS-CoV-2 becomes detectable above background noise. The more viral RNA in the sample, the smaller the CT. It's however important to remember that the CT values are not directly comparable across RT-PCR platforms. At the point of care, molecular tests are conducted using closed systems, where the sample is added in a cartridge where the different reaction steps will take place. Again, RNA is extracted and purified from the patient's specimens and genes are amplified and detected. The output of the point-of-care molecular test will be on the presence of or absence of SARS-CoV-2 RNA. Rapid antigen tests are usually done at the point of care. Antigen tests detect viral proteins, not viral genetic material. These tests should not be considered interchangeable with molecular tests, and we will see this in the next slide. Antigen RDTs are generally less sensitive compared to NAT assays. Remember the definition of sensitivity. Sensitivity refers to the percentage of SARS-CoV-2 infected patients who are correctly identified as having SARS-CoV-2 infection. Thus, low sensitivity means there are generally higher false negative results. Antigen RDTs work best in phases with high viral load, which is generally 1 to 3 days before and within the 5-7 days after onset of symptoms. Infections with low viral loads may be missed. This is illustrated in the figure, where the areas with blue stripes represent viral loads which would be detected by RT-PCR assays, but not using antigen RDTs. As general recommendation for the use of antigen RDTs, follow your national or local testing strategy, which defines when and when not to use antigen RDTs. WHO advises that SARS-CoV-2 antigen RDT testing can be considered if there is widespread community transmission of COVID-19, if the health system is overburdened, and or if it is not possible to test all suspected cases by molecular testing methods within an acceptable turnaround times, which would be of less than 48 to 72 hours. The test used should meet minimum performance criteria of 80% or more sensitivity and 97% or more specificity. You can refer to the WHO guidance linked on this slide for more information. When molecular tests or nucleic acid amplification tests such as RT-PCR are not available, and there is widespread community transmission of SARS-CoV-2, antigen rapid diagnostic tests may be used. A trained operator should take the sample. If SARS-CoV-2 is detected, the patient should be isolated or cohorted according to their symptom severity. For example, if the patient has severe or critical disease, the patient should be admitted to the hospital. If the patient has mild or moderate disease, home or cohorted isolation in a designated center should be considered. In the case where SARS-CoV-2 is not detected, but the concern of possible infection remains and the negative predictive value of the test is high, patients should be referred to a ward designated for suspected cases, while other causes of symptoms are explored. If SARS-CoV-2 is not detected and the concern of possible infection is low and the negative predictive value of the test is low, advise patients to exercise infection control practices and consider repeat testing if symptoms progress or persist. Now, in a slightly different scenario, when molecular tests or nucleic acid amplification tests such as RT-PCR are available but only in a limited capacity, and there is widespread community transmission of SARS-CoV-2, antigen rapid diagnostic tests may also be used. A trained operator should take the sample. If SARS-CoV-2 is detected, the patient should be isolated, cohorted according to their symptom severity. For example, if the patient has severe or critical disease, the patient should be admitted to the hospital. If the patient has mild or moderate disease, home or cohorted isolation in a designated center should be considered. If SARS-CoV-2 is not detected, but the concern of possible infection remains and the negative predictive value of the test is high, patients should be referred to a ward designated for suspected cases, while other causes of symptoms are explored. If SARS-CoV-2 is not detected and the concern of possible infection is low and the negative predictive value of the test is low, A sample for a molecular test such as RT-PCR should be taken and the patient should be isolated until the results are available. We're now going to talk about serology. Serology can detect virus-specific antibodies such as IgA, IgM, IgG, or total antibodies using immunoassays. Serology is neither interchangeable with and does not replace nucleic acid amplification tests or antigen tests for detection of SARS-CoV-2. Serology should not be used as a standalone diagnostic test to identify acute cases in clinical care or for contact tracing purposes. When the clinical suspicion for SARS-CoV-2 infection is high, but is not supported by adequate and repeated nucleic acid amplification testing, serology can support in determining retrospective SARS-CoV-2 infection. In this situation, a serum sample taken in the acute phase of illness, as well as a sample at a later time point, generally 2 to 4 weeks later, should be obtained from the patient. Interpretation of serology test results should be made by an expert. Interpretations depend on several factors such as timing of symptoms, clinical morbidity, the epidemiology, and prevalence within the setting, the type of test used, the validation method, and the reliability of the results. Detection of antibodies to SARS-CoV-2 does not guarantee that they are neutralizing antibodies or that they offer protective immunity. There are also several non-specific laboratory abnormalities that have been described in COVID-19 infection, such as leukocytosis or elevated white blood cells, lymphopenia or decreased white blood cells, increased neutrophils, elevated aminotransaminase levels, decreased albumin levels, elevated lactate dehydrogenase levels, elevated inflammatory markers such as the C-reactive protein, the erythrocyte sedimentation rate, interleukin-6, ferritin, D-dimer, hyperglycemia, prolonged thrombin time, and elevated activated partial thromboplastin time, elevated fibrinogen, and increased fibrin degradation products. An elevated D-dimer greater than 1 microgram per milliliter has been determined to be an independent risk factor for mortality. When SARS-CoV-2 is suspected, do not forget to also consider other co-infections. Remember, a positive test for SARS-CoV-2 does not rule out co-infection with another pathogen or another etiology for patient symptoms. In an acute setting, collect additional specimens to aid further in laboratory evaluation. For example, if in an area of high prevalence of tuberculosis, consider sputum for bacteriology. Specimens should also be taken from other sites that may be infected, such as urine, cerebrospinal fluid, stool, pleural fluid, peritoneal fluid, and can yield pathogens as clinically indicated. For patients with sepsis, 2 sets of blood cultures for bacteriology from 2 different sites where possible should be obtained. Please note that SARS-CoV-2 has not been shown to be transmitted by blood. So this concludes the module on laboratory considerations for COVID-19, part of the clinical management course series. We've listed here for you some additional resources on this topic. Thank you very much for listening.